Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Jay Calvert today, here with my most non-dysmorphic co-host, Dr. Millicent Rovelo. Dr. Rovelo, how are you? Doing okay today? Are you non-dysmorphic?
I would say that
somewhat?
I'm like mildly dysmorphic on the best of days.
I knew you were going to say that. I knew it. I knew that was coming.
And like a little more on the worst of days. Because I mean, who's not, right?
Well, it's true. I mean, we all look at stuff, we're like, ugh. And no matter like how we look, we all are critical
of
ourselves. We are, some less than others.
Yes. But to be fair, a certain amount of dysmorphia is normal, but the kind that we are talking about today is the abnormal, pathologic kind, the kind that actually has a formal psychiatric label, body dysmorphic disorder.
Correct. In the psychiatric world, this is a known disorder, and it causes people a lot of problems.
Right, because what they see when they look in the mirror and the image that gets translated to their brain is not at all what the rest of the world is actually seeing. So they see the tiniest areas of deformities or no deformity, and in their mind, it is the biggest, most ugliest, worst possible thing that could ever happen to them. And the rest of us are left going, huh?
Yeah, and just, this happens where, and this is what tips me off to the diagnosis that I clearly missed. It's after surgery, and you're standing there with a patient who has a great result with whatever, and there's me and the nurse and my scribe and the fellow, and the patient's pointing to stuff that isn't right in their brain, and we're all going like, what are you talking? You look great. Have you seen you? Because you look amazing. This is a great result. And they're like, what do they pay you guys to say that? Well, no, we want you to be happy with your result. And clearly the result that you have is not only acceptable, but it's good. And yet you're seeing something that makes you anxious and cringe and angry. And it's not there.
It's not there. And unfortunately, typically that is when we find out that a patient has body dysmorphic disorder. It's after we've operated and all of these problems and the tears and the questions and the concerns and the anger come up and you go, oh, okay, I see what's happening here. Ideally, we'd pick it up before. And
it's hard to.
It's hard because I would say a fair amount of our patients are on this spectrum that most of us are on. Some patients come into the plastic surgeon with an obvious deformity that we can fix and everybody sees it and it's like, yes, that's appropriate. But there's also a fair amount of patients that come in looking great already. They just want to look better. So maybe their friends or other people in the public would be like, I can't believe she's getting plastic surgery. She already looks so good. What's wrong with her? But to that patient and to the plastic surgeon, we say, yes, you look great, but we can make it better. We can give you bigger breasts. We can give you smaller breasts. We can do a little bit of lipo here. So there are variations of like kind of what's acceptable on the body dysmorphic scale. But we're really talking about the ones that come in with red flag warnings where, yes, like I just said, a lot of times we miss them. But if you pick them up ahead of time, it's the patient that is perseverating over a very minor defect or a very minor flaw or problem with a previous plastic surgery. Or they come in and say that they've seen 5 other plastic surgeons who haven't wanted to help them. That is a huge red flag. That is like, put the brakes on.
Yeah, for sure.
My hecklers are going up.
It's really hard. It's just really hard to pick it up before because typically, we're empaths.
Right.
We are empathetic.
We want to help. Yeah, and
that's what we do. And when patients complain and they're pointing at stuff, you kind of want to help.
Right. The problem is when there is something you can do.
That's right.
When you're pointing at something and maybe it's small, but you're like, yeah, I could make that better. And that's where the pitfall comes in because you're trying to help and you're like, yeah, I see what you're seeing and yeah, we can make that a little bit better. And then little do you know, you've just put yourself in this rabbit hole of like, oh no, never going to be happy. Because that's the problem. The plastic surgery does not fix the underlying problem, which is a psychiatric diagnosis.
That's right. And you shouldn't be having surgery when what you need is to see a psychiatrist or a psychologist who can help with your body dysmorphia. And, you know, it's tough because all the things that we've already mentioned, but, you know, we really think that we can make it better.
Yes, that is really the problem. Because very rarely is that the classic, you know, open and shut case where like some skinny BMI of 19 person comes in and says, I want, you know, liposuction here. And you look and you say, what are you talking about? Or like they point to a perfect nose and they say they want, like those cases are very rare.
Right, the clear-cut BDD
where there is not a thing wrong with you and you are making it up. Usually there's a little something that the average person would look at and be okay with seeing. But it could be better. And that's the trap, right?
And maybe it's partly our arrogance that says, you know, well, they just haven't had surgery by me. That's the whole thing. If they'd had me do the first operation, they'd be great. But, you know, they wouldn't be because they still have BDD. Yeah. And so that's where it is. And yeah, I mean, I will mention this not because I want this person to take down the review, but like one of my 1-star reviews, the patient posted the photographs and the result was so spectacular that it actually brought patients in. and people read this scathing 1-star review and the patient post their photos and they were just like, if that's a total disaster and destroying somebody's life to look like that, sign me up.
I'm in.
Destroy my life with that nose because that is amazing. The patient did have a 1 millimeter discrepancy from one nostril to the other, which, by the way, most people do. And so that's the problem, is that if you're going to perseverate on something like that, that's not normal.
That is not normal. Right.
You know, I'll reference the nostrils. The nostrils podcast. It's not normal because you don't like my nostrils are so different and so wrong, and you know rugby was not kind to this nose, but it's fine. You know, maybe people think like, dude, you need surgery, which I get it, and that's fine. Maybe I have BDD in reverse, like, no, dude, you need a nose job. But for me, it's fine, and for the average Joe and the average Jane, some nostril asymmetry is totally acceptable.
And it's acceptable. And it's so you can have plastic surgery. And I guarantee you, no matter who your surgeon is and how fantastic your result is, it's not going to be 100% perfect.
Ever.
There is going to be a little something that could be revised, that could be addressed, that could make it better. The average person will look at their results and be like, it's great. I love it. I see that imperfection. Doesn't bother me. I'm ecstatic.
Right.
The BDD patient will see that tiny, tiny, tiny imperfection and perseverate on it and go down a rabbit hole, and they will cry for days about it, and they will get mad and they will get angry and they will say things like, it's ruining my life.
Oh yeah.
And
I can't get any jobs as an actress. You know, it's destroyed my self-esteem and and it's like your nose is so much better and so much more fitting for your face.
But they can't get past that one little thing. But the problem becomes when they try and act on that one little thing that's not exactly perfect in their result, and so they have another surgery. And then they have another surgery. And by the time they continue, they've messed up what was a really good result. And now they may have a potential disaster on their hands. And that is one of the problems of the BDD patient, is that they can actually end up with really bad surgical problems.
No doubt. And that, especially in revision rhinoplasty, it's like, oh my God, like you don't want to take something that's really good. And this is what I say to patients. I go, look, if you can live with this nose that you have right now, that, you know, was done elsewhere, then do that. Don't do a revision, because a revision rhinoplasty carries with it real risk
Oh, yeah.
You get an infection, the wheels come off. Like that, there are things that can happen that can take you from, I have a pretty decent result to like, now I need a forehead flap very fast.
Right.
So you only have that revision rhinoplasty if you can't live with the result that you have. And if 4 or 5 other people are standing around you going like, your result's fine, don't do it, then don't do it. The only people who should get revisions who are people who are going to really benefit and are going to be happy that they did it.
Right.
The BDD patient is not going to be happy.
No.
You could fix any minor imperfection and they're still unhappy.
Happy.
And I'm sure, that, the patients that I've had to discharge from the practice, which is never a fun thing and never, goes over well and usually results in a 1-star Yelp review, which is fine. But, because that's the way that it is. I'm not going to take somebody to surgery and hurt them because of their psychiatric problem. I'm just not. Like, and I know other guys will. They'll be like, oh, we'll just do a little. I've heard it.
Yeah. Well, it's easy to do. You want to make them feel better.
And it's easier than fighting the good fight.
Yeah.
Because
it's hard. It's really, that sounds really lame coming from a plastic surgeon. It's really hard to say no to a patient, but it is really hard.
It is.
It is because they came to you for something. They want you to do something, or they wouldn't be there.
That's in our nature. That's what we do.
Yes, I can. And so to say no and to upset them is actually hard.
It is, and I take a beating over it.
Yeah. And they don't want to hear that maybe they have BDD. Maybe they've heard that before. Maybe they haven't. Maybe they have no idea. Regardless, they don't want to be told that because nobody wants to be told that. And that's hard to tell someone. That's really hard to say that maybe you should get a therapist. Maybe you should get some help. That's a really, really hard conversation to say. And it's probably just easier to operate.
Yeah. And that's the problem is that, it's like telling somebody who's having massive anxiety to relax.
Just relax,
just
man.
Relax. It's going to be
chill.
fine. What are you talking about? It's like you can't relax then. And somebody telling you to relax when you're in that state is not helpful.
Not helpful.
And so that's why, ultimately I've had to discharge some patients from the practice because they were basically like, saying you either operate or I'm going to hurt you. I'm going to hurt your practice. I'm going to hurt your reputation. And I kind of said, well, you're going to have to do that because I'm not operating. And that's reality. That's the reality of doing what I do. I mean, I do revision rhinoplasty. I mean, I asked for it. So, is it good that I do that? Yeah, because I help a ton of patients. And the ones that I don't help, I'd rather take the 1-star review and the angry phone calls and, they haven't thrown eggs at me yet, but like I'm sure that's coming. I'd rather do that than operate because then it's like that now you've done something worse. You've done surgery when you really should have just sat on your hands and said, "I'm sorry, we're done here."
Yeah.
And this is what BDD is, and that's why it was important to do this podcast because when you're dealing with BDD, you don't need surgery. You need psychiatric intervention of some kind.
That is true. And it's hard. We definitely see our fair share of it, probably more of a skewed amount than anybody else does because of the line of work that we're in. But it's sometimes it sneaks up on you. Sometimes it's obvious, but it's hard. It's hard for us and it's hard for them.
Yeah.
It's really hard for the patients because
hard for the patients.
In their defense, they really see it.
Yeah,
their brain is literally telling them that this is catastrophic.
Yeah, and that's the hard part because you're there knowing that they see it. I just had a patient with this. I mean, she was standing in front of us, showing, this beautiful mastopexy augmentation, amazing lipo, like right and my scribe is in the room, my fellow's in the room, there's a nurse in the room, and we're all looking at her and we're like, you look amazing. And everything that she's complaining about are the routine results and the routine sequela of having plastic surgery. But this is swollen here and this is I was like, yes,
you're making me like cringe. I know that room. The feeling in that room is just
it's
so
hard.
hard.
And their brain isn't working right. It's just that it's not that they don't see it as a problem. It is a problem for them, but it's all like
it's literally in their
I said
head,
if I lined up 100 plastic surgeons to walk in here and talk to you about this, they'd all say the same thing. Yes, routine results from plastic surgery. That's what it looks like.
Yeah.
You know, and that's what
it is. That's the deal.
That's how this works. It's like, I mean, what did you, and I remember, because she's looking at the scars on her breasts and going, oh, these anchor scars, da da da. I remember drawing them on the consent form. You know, I was sitting there with her going like, you are going to have an incision around your areola, one down in front, and then the scar underneath in the inframammary fold, and drew it on the consent. And she goes, if I knew I was going to have these scars, how could I even have this procedure? I go, you did know. Not only did we go over it in the pre-op, not only did we talk about it, I drew it on the consent form and showed it to her, and she was just like, well, that doesn't mean anything. I'm upset. And it's like, I know you're upset. I know it.
That hurts.
Yeah, it's real, because what do you do?
Hard.
You know, like, what can you do there? You know, at that point, you might as well be arguing that, you know, the sun is blue.
Right.
It's not yellow.
By the way,
at all.
you look amazing. And if I hadn't done those scars, you would look way less amazing. So I'm not sure what we're arguing about here.
Yeah, I mean, and that's why I'm just like, you know what? This really has to go a different direction, because there's nothing I can do.
Yeah.
At that point, I'm a surgeon. I'm not a psychiatrist. I mean, we kind of have to be able to recognize that, but I missed it, you know, and I missed it pre-op, and you know, I have some questions I ask people, but I always say, you know, are you going to be okay with these scars? Yes, I am. Yes, I'm going to be. Oh, totally, doctor. That'll be great. That'll be fine. You know, and that's why I document it as such, because afterwards, when the BDD kicks in, it's like, oh, I never agreed to this. It's like, well, you did though. Like here it is. Like you really did agree to it. You know, and there's, you know, my scribe going, yeah, you kind of did. Like I wrote it down, like on your pre-op visits. By the way, just another little tidbit. 3 separate visits before booking surgery. Mm-hmm. The biggest of red flags, and documented as such in a Duke University study. So if it takes them 3 visits to you to discuss the operation that they want, don't bother. They're not going to be happy. 'Cause, you know, not including the pre-op. Like 3 like investigational, like, what if we did it this way?
Yeah.
What if we had it that? Do you think that if we get it like, in, you know, where
that is so true. I'm like
3
going through my head. I'm like, oh, yep. Mm-hmm.
So 3 preoperative visits. And for you patients out there, same thing. If it takes you 3 times to go in, don't have surgery.
Yeah, it's not for you.
Yeah, like this should be like a 1, maybe a second little, okay,
maybe
I'm ready
a second one, and then you're pre-op.
Right. Once you hit that 3rd one, it means that this isn't for you.
Either you don't trust your surgeon,
Right.
you don't really want to do
Punt.
it. Something's a problem.
Right.
Yeah.
So punt and get out of your own way, because that's not how plastic surgery should work. It should be, okay, came in, I met Dr. Rovelo. She's lovely. She's going to do a great job. Lots of before and afters. Been in practice for lots of years. She's great. I'm signing up. Oh, maybe I have one other question. Do you think we could do it this way? No, we're not going to do it that way. Blah, blah. Okay, great. Then the pre-op visit and go. That's acceptable. 3 visits to figure it out.
No, we should have something like on our EMR, like for our office staff. Like if when they've come to book their 3rd consult, like this big red glaring X should pop up and like horns should go off. Like,
I mean, doesn't it make sense though? Like how, like if you want to, like when I want to get like my dental implant, I don't go into Doug Galen and say like, hey Doug, you know, how about this thing? I don't know. I'm gonna have to come back and talk to you. No, I'm like, I don't have a tooth. I left it on the rugby field.
So I've been doing some research, and I was wondering, is it possible that maybe we could just put it in upside down? Because I'm worried that if we put it in right side up, there's going to be a reaction to it. Because I read about this other patient on Facebook who told me that.
Yeah, exactly. Yeah. He'd be like, goodbye. I mean, that's the truth. Like I went in and talked to him, and I said, I need this done. He goes, great. This is how we do it. Da, da, da. And, what kind of, you know, this, you know, and I went to, you know, Marashi to find out what kind of tooth. He's like, this is the color we're going to use. I'm like, great. And do it. It shouldn't be like, ooh, I don't know. Like, does Doug really know what he's doing? You know, Doug Galen is a world expert dental implant guy. Like, I don't have to ask those questions.
Yeah.
You know, and so that's where when you see patients that are doing that sort of multiple, you know, multiples of multiples going through it, it's like, oh, you know what? This isn't a good idea.
This is not going to work.
Yeah, don't do it. You're not going to be happy. You know, wait, get some more information.
Yeah, I like this. I like
else.
this. This may simplify my life.
Yeah, I bet it will. Mm-hmm. And that was...
I have one coming up, and now I'm like, I mean, I had to
That's the
reconsider that one.
third visit right there.
Yeah.
And Duke showed it that no matter what, those patients are 100%
Not
never happy. Never. Like no matter what you do, no matter what you revise, they aren't happy. And it's a 3 evaluation visit rule. So,
Well, there you have it, folks. You only get 3 visits,
no,
and then
you get 2.
You get
Once
2.
you get the third one,
You're out. That red, red X, it's on your chart.
That's right. You'll have to walk down the hall. I know somebody will help you out down that way. I don't, really, it's just like, it does make sense though.
Totally.
So that may be an indicator of BDD.
I like that. I like that rule.
I don't know if that's, like I'm saying, that maybe but that study was really clear about it. So
right.
and that's why, again, this podcast is really important because people can get the information that they need so that they know how to do research. They know the questions to ask because we're trying to make it easier for people to get great results. And, if you hit snares and you hit walls, don't ignore it.
No. And I don't know that if you need 3 visits, it means you have BDD, but it means that there is some underlying anxiety or other issues going on that
surgery is probably not a good idea.
Probably not the best thing for you right now.
And you're not going to be happy.
And yeah.
And that has been the case with me too. Those 3 visits, and I have patients where I look back and I was like, that is so it, and first visit, oh yeah, it's great. And then come back, oh yeah, it's gonna be great. One more visit, oh yeah, it's gonna be great. Okay, I'm ready to have surgery. It's like, why did it take 3 rounds of the same discussion? Like, what's going on then?
Right.
Because I'm the same guy that met him the first time.
Yeah.
I said the same things. Yeah, as a surgeon, like just for the general public, like as a surgeon, your goal is to really get people the best results possible and to be as transparent, forthcoming with as much information as you possibly can so that the patients can make a good choice for themselves. But we also have to make a good choice for you in terms of what can and cannot be done. And reality is very different than, what is written on the internet and television shows and like reality is what goes on in the office with us and our patients. Right. That's where the rubber meets the road. And you got to listen to that. And you got to be clear at where you're trying to get to so that you can make a great roadmap and get a great result.
Agreed. And get some help if you have other issues going on.
100%. Well, I think that's it. That's our Dysmorphia podcast, which I think is a very important one. And this is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.